The implantation of trapeziometacarpal prosthesis begins with the identification of anatomical landmarks: the trapezium, the base of the first metacarpal, and the thumb length. A longitudinal skin incision centered on the dorsal aspect of the trapeziometacarpal joint is then performed. Using blunt dissection, the sensory branches of the radial nerve are isolated and retracted. A full-thickness longitudinal capsulotomy is carried out, aiming to obtain two capsular flaps, a dorsal one and a palmar one. A sizing tool is used to determine the amount of bone to be resected from the base. You can put a mark on the base, and then the first resection is performed longitudinally, and the base of the metacarpal is removed. Now, an oblique osteotomy is carried out to excise the volar osteophyte of the metacarpal bone, which could otherwise cause implant impingement and instability. A canal finder is used to identify the central axis of the metacarpal canal. The metacarpal canal is then progressively prepared with rasps until a satisfactory fit is achieved. There are 6 sizes of rasps for the metacarpal channel. A proper fit is confirmed by the resistance upon insertion and by the synchronous movement of the metacarpal and the rasp during rotation. Now, either the trial or the definitive stem can be inserted and implanted at this stage. Capsular release should be completed both volarly and dorsally to release completely the joint from the ligaments. The medial osteophyte of the trapezium is then removed using an oscillating saw or an osteotome, and other osteophytes can be also excised to regularize the trapezial surface. With the specific retractor in place to expose the trapezium, its center of rotation is identified and the guide wire is positioned to prepare the socket for the cap component. Fluoroscopic verification is performed to confirm that the guide wire is in the center of the trapezium and oriented perpendicularly to its articular surface to the scaphoid. This verification is done in 3 projections: anteroposterior, lateral 1, and the Roberts view in hypersupination. The cap socket is prepared using dedicated reamers, which may be motorized or manual, advancing 1 or 2 mm below the cartilage surface of the trapezium. The first reamer is conical and sets the depth. The second one is specific to the type of the cap to be implanted, conical in this case, though spherical variants exist. The second one creates a precise cavity within the trapezium. Once the full seating of the reamer is confirmed, the guide wire can be removed and the trial cap is inserted. A secure press fit should be observed, with the trial cap remaining in place by itself without displacement, confirming the adequate preparation. The definitive cap is then implanted using a dedicated holder to avoid the contact with the porous surface. It is impacted into place using a specific impactor, and its stability is verified. Trial head and neck components are inserted using the appropriate forked instrument, aligning the stem anti-rotational tip with the notch at the base of the neck. The implantation is assessed using a piston test, checking thumb range of motion and tenodesis effect. 3 sizes of straight necks and 3 with a 15 degrees offset are available. If the tension is satisfactory, the definitive components are implanted. Only a gentle impaction is required to ensure secure fixation of the conomorph system. At this point, the implant is reduced with the proper instrument, and final assessments of mobility and then piston tests are performed to confirm implant stability, and they are followed by intraoperative fluoroscopic checks in the same 3 projection. Capsular closure is performed with separate absorbable III sutures, and an intradermal skin closure is completed at the end, reinforced by stereostrips. Finally, thumb length is checked and a soft partial immobilization dressing is applied.